dear student. On behalf of the Foot and Ankle Department of UKM, it's my great pleasure to welcome all of you here today to discuss on Clinical Pathological Conference for today. We are gathered here today to explore an important and challenging case titled Progressive Ankle Pain and Functional Decline in an Elderly Patient, Treatment and Challenges. Today's session brings together a multidisciplinary team comprising of orthopedic surgeon, radiologists, and physiotherapy who will share their insight and perspective on this case. Without further ado, let us begin this morning conference by recitation of prayer by Dr. Fakri, followed by case presentation by Dr. Jit Sen.
Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala ashrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Ya Allah, Ya Rahman, Ya Rahim, sesungguhnya kami berhimpun pada hari ini bagi menyatakan kesyukuran di atas kurnia-Mu yang tidak ternilai. Jadikanlah kami hamba-Mu yang sentiasa bersyukur sama ada nikmat yang sedikit, lebih-lebih lagi nikmat yang melimpah ruah kepada kami. Ya Karim, Ya Wadud, Engkau berkatilah dan rahmatilah perjalanan program CPC kami pada hari ini, Ya Allah. Kurniakanlah kepada kami ilmu yang bermanfaat. Sinarilah hati-hati kami dengan cahaya dan hidayah-Mu, Ya Allah. Semoga dengannya kami mudah menerima dan menghayati serta mengamalkannya. Ya Zal Jalali wal Ikram. Kurniakanlah kepada kami kesihatan anggota, kecerdasan minda, ketenangan jiwa dan kekuatan semangat. Semoga dengannya kami mampu mendepani cabaran, berdaya saing dan mampu mengangkat martabat diri keluarga, masyarakat dan negara. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin.
Good morning, everybody. Dr. Jit Sen here. I'll be starting off with the case presentation. So this is a 66-year-old man who complains of a right ankle pain for the past 15 years. The pain score is 4 to 5, which affects his activities of daily living, mostly mechanical in nature. So the pain is aggravated by walking and relieved by rest. Okay, this is just to we want to exclude some differential diagnosis. So the pain is not associated with any food intake. He denied night pain, small joint pain or swelling, morning stiffness, any claudication pain, no history of previous trauma, no fever or any constitutional symptoms, no TB contact and no family history of connective tissue diseases. Okay, so for the past 15 years, so it's a long time. So he already failed conservative treatment and has underwent multiple procedures. Okay, so started off in 2010. Which is arthroscopic debridement. Okay, so you see the timeline from 2010 to 2015 means in between this period, the 5 years period, he has a pain-free ankle, so to say. So once he has the pain recurs, he seeks treatment back, and then they offer them another surgery. So all these 5 procedures are done elsewhere, not in UKM. So 2 arthroscopic debridements followed by a supramedullary osteotomy. I know the audience here are mostly medical students. We will touch into these topics further in the discussion later. Okay. So remember the last surgery done was in June 2024, which is a revision total ankle replacement. Okay. So after that, he has pain-free for around 6 months, but then the pain recurred. Between that period, there's no fever or any wound complications. He then came to here, HCTM for another opinion with intention to retain the ankle range of motion. Okay, so this is a brief history and summary. I would like to invite Dr. Aravind for his comprehensive talk on the examination of the ankle.
Good morning, my name is Dr. Aravind. I'll be talking about the clinical examination for this patient. So from the history that you all know that he has been undergone a few operative surgeries for the ankle. So I'll be talking about how would you approach for a clinical examination for a patient who comes for the first time with a progressive ankle pain. Okay. So first you start with the same principles of orthopedic examination. You look for general examination, then you go for the local. Local you have look, feel, move, measure, and special tests. So on general examination, patient is a well-built gentleman. He has a well-healed surgical scar over the anterior right ankle, and there is no swelling, there are no effusions, there are no redness. So in inspection, you look at the skin, you look at the scars, you look at any swellings, either bony swelling or any joint effusions, you look at the skin color. Okay, then you have to go into a localized examination. You can separate the foot and the ankle in a few parts, namely the forefoot, midfoot, and hindfoot. So the forefoot consists of metatarsals and your toes, your midfoot are your tarsal bones, and your hindfoot is your tibia, talar, and calcaneum. So what you should be looking at, what you should be knowing is that in the forefoot you have these deformities such as claw, hammer, and mallet toes. You have bunions or overriding toes. Then you have callosities, nail changes. Okay, so these are the deformities you need to look for at the forefoot. In the midfoot, you have to look at the medial arch of the foot. So this is a normal medial arch of the foot. So this is a neutral arch. Pes planus means there is loss of medial arch. Where the pes cavus, there is increase in the medial arch. Too many toe sign, you see if there is patient with a pes planus, you look posteriorly. Rocker bottom foot is the finding that you see usually in Charcot foot. So next you go to the hind foot, you look at the alignment and the deformities as well. You look from the back, you see if there is any valgus deformity or a varus deformity. Then you look at the muscle bulk, the soft tissue. First you state muscle atrophy. For this is a clinical photograph of the patient. The right ankle, you can see there's obvious muscle atrophy. The calf muscle has been wasted compared to the right side. And posteriorly also you look at the Achilles tendon, the continuity as well. You can see the cord-like structure running at the back. So you have to see if there's a continuity or if there's any step. Next, you assess the gait after the inspection. Ask the patient to walk. The usual gait that you find in this kind of patient is the antalgic gait, which is produced because of pain. So how you describe an antalgic gait? It is a shortened stance face on the affected limb. As you can see from this video over here on the left side, where you have a stance and a swing face. So she is basically stepping lesser time on the affected side. So which means there's a shortened stance face, which is usually called an antalgic gait. Once you're done with the inspection, you go to the palpation, feel. So there are a lot of bony landmarks and soft tissue landmarks in the foot and ankle. These are mostly what that is covered, the tibia fibula, lateral and medial malleolus. There's also this ankle joint that you need to palpate for. You have to palpate for all the bones, all your tarsal bones, all your metatarsals to inspect for any bony protuberance, deformity, or any tenderness. And swellings as well. Once you've done palpation of the bone, you have to look for the ligaments and tendons. So the ligaments, these are the anatomical landmarks where you should palpate for your ATFL, anterior talofibular ligament, calcaneofibular ligament, and posterior talofibular ligament, which is just anterior, distal, inferior, and posterior to your lateral malleolus. This is the outer side of the ankle, okay? So next, you palpate for the tendon. The most major tendon is the Achilles tendon. Lying patient on prone, palpate along the Achilles tendon, and you look for any tenderness, and you look for the continuity of the tendon if there's any step deformity, which could suggest a partial or a complete tear. Then the posterior tibial tendon, you go over to the medial side. It runs just posterior to the medial malleolus, to the midfoot. So you have to palpate the posterior tibial tendon for tenderness as well. And over on the medial side, another palpation point is the deltoid ligament, which is just distal to the medial malleolus. So once you're done with palpation, movement is range of motion of the ankle. It's not just flexion and extension. You have multiple movements, and which is at the tibio-talar joint is your ankle dorsiflexion and plantar flexion. Subtalar joint is where you have your inversion and eversion. Inversion means your sole goes inwards. Eversion means your sole face outwards. And you have a combination of movement which produce supination and pronation. And then for the forefoot, you have your abduction and adduction. So all range of motion, you have to remember, you have to do active, which means patient does it first, and then you do passively, you do it. And you have to compare the range of motion and document the angle on both sides. Once you're done with the movement, then you go to special test. This is a special test to look for any pathology of the ankle and the foot. Number one, you go for the anterior drawer test. This is to check for the integrity of your ATFL. Anterior drawer test, patient resting, you hold the calcaneum on one hand, and then you have to stabilize the distal tibia and fibula on the other hand. Draw the ankle forwards, draw the ankle anteriorly, and you will feel if there's any talar movement, excessive talar movement along anterior to the tibia. Next is the talar tilt test, which assesses for CFL or calcaneofibular ligament as well. The same movement for the distal tibia fibula and the calcaneum. However, this one you are giving an outward force, a lateral external rotation force, to see the talar dome shift laterally from the tibia. Next, jack test. If you find that patient has a reduced medial arch or a pes planus, you have to differentiate if it is a rigid flat foot or a flexible flat foot by dorsiflexing the first metatarsophalangeal joint, your big toe. When you dorsiflex the big toe, you will see that there is restoration of the medial arch of the foot, which means that it is a flexible flat foot. Next is the syndesmotic squeeze test. Syndesmotic squeeze test is to test for your syndesmotic injury. What you do, syndesmosis joint is the joint interosseous joint which exists at the distal part of your tibia and fibula. So what you do, you just squeeze the distal tibia and fibula, give an inward force, and then if it is positive, if patient will have pain, basically. Silver score test is basically to test for if the patient has ankle contracture, which means there is reduced dorsiflexion of the ankle. So one of the causes of ankle contracture, you have to find out where is the site of the pathology. Either it's at the Achilles tendon, or if it is more proximal at the gastroc muscle. So how you do this? Two motions, one in knee in extension, another one in flexion. So first in knee extension, dorsiflex the ankle first. You document the range of motion. So it is tight now. So what do? Then you flex the knee. Once you flex the knee, you have to assess if you can get more dorsiflexion of the ankle. So if you manage to dorsiflex the ankle more once you have flexed the knee, that means that the gastroc muscle is tight. This is because the origin of gastroc exists above the knee joint. So when you relax the knee joint, you're supposed to get a better dorsiflexion. So knee extension, the ankle dorsiflexion is tight. When you flex the knee, it is still tight. That means the issue is not with the gastroc, it is with the Achilles tendon. This is important if you want to do ankle contracture corrections. You need to know where you want to do surgery, where you want to do the release. Next is a Thompson test. Thompson test is check for the integrity of the Achilles tendon. Basically, put patient in a prone position with the foot and ankle overlying the edge of the bed. Then you squeeze the calf. So the ankle at rest, when you squeeze the calf, you're activating the Achilles tendon, the ankle plantar flex. If there is no presence of plantar flexion, that means there is no continuity to the Achilles tendon, which means there is a tear of the Achilles tendon. Single leg heel raise test. This is to check for posterior tibial tendon integrity. So there are two motions, how it can be positive. On the left side, you can see that on a single heel raise test, patient is able to do it, but not fully. That means there is pain limiting full heel raise. That is number one. If there is pain, there could be a posterior tibial tendon dysfunction. Number two, on the right side, you can see that another function of posterior tibial tendon is that the hind foot, once you have raised, the hind foot is supposed to invert back to a neutral position. This one, the hind foot is not inverting. That means that it's also positive for posterior tibial tendon dysfunction. So once we're done with all the look, feel, move, you have already done your special test, you have to complete your examination, you do a brief neurovascular examination of the foot, basically your dorsalis pedis and your posterior tibial artery. The anatomical landmarks of palpation are there. Dorsum foot over the second metatarsal. For dorsalis pedis, your posterior tibial artery is behind your medial malleolus. Do a capillary refill time to look for the circulation of the foot and also assess the sensation. So once you've completed your local examination of the foot and ankle, now you have your few differentials from your history. You need to rule out with your examination as well. Basically, you have to rule out any primary osteoarthritis signs, inflammatory arthritis signs, and also look for any causes elsewhere, which is more proximal to your foot and ankle. So you look for any small joint swellings with the hands and toes, no rheumatoid nodules, which suggests any rheumatoid arthritis, no psoriatic plaque for psoriatic arthritis, no gouty trophi. Haberden notes, Burkhardt notes, you look for first CMC, carpal metacarpal joint. You grind it, if there is tenderness, this shows that these are signs of primary osteoarthritis. Do a spine examination because it could be a referred pain or a radiating pain from the spine. Just do a brief one to rule out cause from proximal. So that will be all from examination. Thank you. Now I would like to invite my colleague, Dr. Nazrin, for the next presentation.
Thank you, Dr. Aravind, for the presentation. Assalamualaikum and good morning, everyone. I will continue on from here. So after we have gathered enough information and especially regarding the patient clinical history and also the clinical examination, of course, next what we should do is we need to summarize all this knowledge to help us to guide in making the diagnosis. So this patient actually is 66 years old who came to us with the main complaint of a right ankle pain for the past 6 months. So anybody would like to volunteer what could be the differential diagnosis here? All right. Okay, it's okay. We don't want to waste time. All right. So actually, rather than we think about a lot of pathology or specific diseases around this area, actually we can simplify further across this heading. So we know that the main complaint is right ankle pain. So we can divide into a few headings. First, inflammatory condition, which can either be gouty arthritis, psoriatic arthritis, rheumatic arthritis. It could be either trauma, which include fracture or dislocation. However, in this case, we know that it's highly unlikely it's trauma because patient doesn't have any previous history of fall or trauma. Even the clinical examination also doesn't have any bruises or hematoma or swelling. Tumor or malignancy, in this case, is also unlikely because patient doesn't have any history of red flag symptoms such as loss of appetite, loss of weight, infection, which can include septic arthritis or TB arthritis can be considered. Last but not least, degenerative condition, ankle osteoarthritis, or which include primary or secondary osteoarthritis. All right. So, okay. Of course, we need to take note that this patient actually have multiple surgeries done, and he even gave history that implant was inserted into his right ankle. So, we can add up another category here, which is implant failure or loosening. Okay, which can either include aseptic or septic loosening. All right. So moving on, how do we further narrow down our diagnosis? Of course, investigation. So I would like to describe regarding patient blood investigation. And okay, all right. For full blood count and CRP, of course, from the white blood cell and CRP alone, we can know whether this is highly likely of infection or not. However, certain cases such as TB arthritis, sometimes the white blood cell or CRP can be low, so that have to be considered as well. We need to know other parameters such as hemoglobin and platelet in the event of patient have anemic symptoms or any other chronic diseases. And also, if let's say we want to optimize patient for further operative treatment. Uric acid, of course, if we are thinking we want to consider for gouty arthritis, which in this case is low. Coagulation profile, which is normal. If let's say we want to rule out any coagulopathy, this is also important or crucial if let's say we want to do for surgical intervention. Renal profile also is important to know in the sense that in the event of we want to give any sorts of antibiotic or medication later on. Okay, so let's say if we suspect any other inflammatory disease, for example, rheumatic arthritis, we can also add on another blood investigations such as rheumatoid factor and so on. So which for this patient, we didn't think so. Right? So based on this history, clinical examination and lab investigation, so actually we can narrow down this differential few differential diagnoses. So at this moment, it's not inflammatory, it's not trauma, It's really not degenerative. So we pointing more towards infection or implant loosening, failure or loosening. All right. So right. So now we can put our provisional diagnosis here as a primary ankle osteoarthritis, post-total ankle replacement, complicated with possible implant loosening and septic arthritis. So to help us further in our diagnosis, now we move to the next step, so which is radiological investigation. So without further delay, I would like to invite Dr. Emilia, musculoskeletal consultant from our radiology department, to give her talk. Thank you again for your attention. That's all from me.
Assalamualaikum and a very good morning to everyone. Okay, thank you to the Ortopedik team for having me here today. So I'll be presenting on the imaging of this patient. Alright, as mentioned previously, patient had multiple surgeries done in the past. However, the only first radiograph that we have in our center was done on in January 2025. Alright, we don't have any previous imaging to compare. Alright, from this radiograph, we can see that there is presence of implants, alright, at the region of the tibio-talar joint, at the ankle joint. Number 3, yeah. Alright. Alright, so you can see that is a tibial plate, as well as talar plate, as well, and patient has a locking plate along the fibula. Alright, so what complication can arise in cases of post-surgery? First of all, as mentioned by the previous presenters, there are a few things that you need to take into consideration. You need to know the clinical history, whether if there is any signs of infection and so on, and based on the biochemical examination as well. And then we need to have serial previous radiograph to compare for any complications of surgery, number 2. And thirdly, you need to know the timing of the surgery. When was the surgery was actually done for this patient? For this patient, it was actually done many years ago. So most likely the complication is under the delayed post-operative complications. So these complications can be divided into intraoperatively, early post-operative, and delayed post-operative. And in delayed post-operative, the most common one is infection, loosening, which can be aseptic as well as septic, whether there is any periprosthetic fracture, there is osteolysis and polyethylene wear, spacer migration, fracture, etc. So a lot of complications related to the implant. Alright, so when you want to assess for implants, there are few things that you need to see on the radiograph. First, you need to look at the components of the implant, whether there are any signs of loosening, which I will describe later on further, whether there is any migration of the implants, any fractures, any associated bone loss or osteolysis, or heterotopic ossifications. That means there's abnormal ossification of the bone. Alright, again, let's have a look at the zoom image of the same patient. Alright, so this is the tibial component, the talar component, and you have the this linear and rounded structure in between these components, which is the polyethylene insert. Alright, so this is the reference image of a normal, well-aligned total ankle replacement implant, yeah, which is not seen in our patient. Alright, so for radiograph assessment, there are a few things that you can assess. Alright, you can see for the angle, okay, usually all these measurements are taken in serial radiograph to see if there's any changes in the angle of the implant. So any measurement that is more than 5 degrees sequentially may indicate there is presence of migration or even subsidence, which signify there is loosening of the implant. Alright, and another thing that is important is to look at the component bone interface. If it's more than 2 millimeter in thickness, alright, it indicates there is presence of component loosening. Alright, so these are some of the radiographic assessment that we can do in patients with implant. Alright, so let's have a look again at this same patient. Alright, what we can see that is obvious here is that, okay, there is a focal tubular opacity at the region of the medial malleolus, alright, and this is consistent with the previous history of supramalleolar osteotomy. Patient has heterotopic ossifications along the medial malleolus. For the thala component, you can see there is lateral migration of the thala component with associated bone loss, erosion, as well as remodeling of the fibula here. All right. And for the thala component, you can see there is peri-implant lucency along the medial malleolus. So this indicates there is loosening of the component. All right. And there is no aligned, these two components are not well aligned. All right. So subsequently, patient underwent removal of the implant on the 5th of May, and I think on the same day the radiograph was taken. All right, you can see there is swelling of the ankle joint. Okay, a little bit of lucencies around, indicating air pockets. All right. The components, the total ankle replacement implant is no longer visualized. Is replaced by cement material at the tibial-thala joint. All right. The thala, the dome of the talus is not well visualized. It appears slightly flattened here, with the height of about 1.4 centimeter. All right, and a radiograph was done about a month plus later. You see their swelling has markedly reduced after 1 month, okay, with residual swelling at the lateral malleolus. All right. And on this AP radiograph, you can see that there is now some lucency in between the cement and the bone, yeah, which was not seen in the previous radiograph. So this is cement bone interface, yeah. So you need to measure if the thickness of this cement bone interface, and this is more obvious actually on the lateral radiograph if you compare the radiograph. All right, and this confirmed on the CT scan that was done on the same day. All right, you can see the lucency at the cement bone interface. You see the bone loss at the fibula. All right, and you can see that the bones are generally osteopenic. All right, with prominent trabeculation involving the distal tibia, fibula, as well as the visualized foot. All right, these are all prominent trabeculation, which indicates patient bone is actually osteopenic. So subsequently, few months down the line, another radiograph was done. All right, this is just a lateral radiograph. Again, what you see is that it is getting more prominent. Yeah, the cement bone interface with the height of the talus remain relatively similar. So there is no further collapse of the talus, but there is presence of lucency, peri-implant lucency. And when we measure, the thickness is about 2.9 mm. So I mentioned just now, anything more than 2 mm is considered significant. So at this point of time, you need to consider loosening, all right, whether it's aseptic or septic loosening. That's why you have to go back and correlate with patient's clinical condition as well as biochemical correlation, all right. And you look, and other causes of this lucency can be caused by osteolysis as well as thermal necrosis. So basically, the difference between thermal necrosis and aseptic loosening is that aseptic loosening progresses over time. That means the areas of lucency gets progressed over time, but the thermal necrosis is when there is a heat release during the position of the cement that causes some resorption of the underlying bone, but this is stable over time. There is no further widening of the peri-implant lucency over time. Yeah, so this is most likely a case of aseptic loosening. Okay, and we have another surgery that was done on the 30th of November last year. Okay, in this radiograph, you see there is a total ankle replacement and total talar replacement. All right. So the normal talus is no longer visualized; is replaced by this implant, and this is a new tibial implant. All right. You can see the changes in the bone here. There is some areas of lucency at the distal tibia, as well as along the screws. Yeah. Okay. So we compare with the subsequent radiograph, and these areas of lucency is stable. All right. There is no further lucency seen at these regions I mentioned just now. So this implant is actually quite intact.